On today's agenda, we've got compartment syndrome. So we're going to start out by breaking down the different signs you see with compartment syndrome, and I like to call it the 6 P's of compartment syndrome. Just to keep it super simple, you may or may not have heard of them. So the first one we're going to begin with is called pain with passive stretching. This one tends to be very high yield because it's commonly seen as one of the first signs of compartment syndrome. And this is when you have the patient extend their digits because the anterior compartment is usually affected. And this will cause the deep perineal nerve to be compressed even further. Patient will complain of more of a sharp and deep pain because the muscles tend to stiffen up when the pressures are very, very high. So definitely look out for this. I had a patient who got run over by a cement truck, and the only sign he had was pain with passive stretching. And the only injury he had on x-ray was a middle phalanx of the second toe fracture. So definitely look out for this. The second one is pain out of proportion. So even the lightest touch will make them jump out of their seat. The third is paresthesia. So this is when there's a loss of sensation and they feel more of pins and needles. The fourth is paralysis. This is quite rare, and this is when you've got actual nerve loss and damage, and that leads to muscle loss, so they can't move their muscles at all. The fifth one is pyloric and poikilothermia. And this is when the patient can't regulate their body temperature. So when you touch their feet, it feels very cool to the touch. Their capillary fill time is very brisk. So definitely check for this. Then the last one is going to be pulselessness. So this one is the last sign to go. So don't feel like if they still have a pulse, they don't have compartment syndrome, okay? This one only disappears when the pressures are very high. That leads to the artery to collapse. So I'm going to go ahead and underline, and I'm going to make them in pretty green just so these 6 P's stand out. And I definitely want you to remember the pain with passive stretching. So there's a golden star on this. To make this even simpler, I'm going to throw up this picture that I made with the pear representing paralysis, and then the pins and needle paresthesia. You've got the arrow sign, which is dorsiflexion or pain with passive stretching. The heart crossed out, that's pulselessness, and the POP, pain out of proportion. So let's talk about what causes compartment syndrome. The very first one is fractures. Why fractures? Because they can lead to bleeding that causes an increase in compartment pressure, like a water hose with too much water pressure inside of it, especially crush injuries. Like the example I gave with the patient who had the cement truck roll over his feet. Besides the fractures and the crush injury, some of the other causes to look out for would be burn victims. And that is because they have a lot of fluid inside of the tissue compartment, can lead to an increase in pressure. Next is IV drug use, tight casts, very common, and exercise-induced, surprisingly, because of the repetitive use of any kind of injured muscle can increase the pressure. So now that we've covered the causes of compartment syndrome and the different signs to look out for compartment syndrome, let's talk about why and how compartment syndrome actually occurs. So the layer that is affected by compartment syndrome is the fascial layer, which comes after the fat layer. It's the layer that surrounds the muscle and it keeps it all together during contraction. It also helps attach muscle to bone. The one thing is it's not stretchy at all. So it has no elasticity. So now you can imagine any increase in volume will increase the pressure in the compartment, which compresses the vein, artery, and nerve in that specific order. The veins go out first because they have a low pressure inside the lumen, So any sort of changes in pressure leads to the collapse of the veins first, then the arteries, and then the nerve. So essentially, when the vein, artery, nerve are not working, or if the van's not working, we can't deliver oxygen to the surrounding cells. And eventually, if you don't have any oxygen, it's going to lead to ischemia. And then if we get super technical and biochemistry then we are going to release histamine and nitric oxide. The channels become more leaky. And when we don't have oxygen, then we can't produce ATP, which is AKA energy of life in general. And there'll be no muscle contractions, and you're pretty much going to die. JK, but kind of, not really. I'm going to do another illustration here showing how the increase in pressure, kind of like a copper pipe that can't stretch, will lead to the lack of O2 and the lack of nutrients to all these different cells and necrosis. So there's my beautiful picture. So this gets us to our next topic, which essentially is how many compartments are there in the foot? Well, just kidding. You're probably not wondering, but need to know it for some tests down the road. So I'm going to tell you anyway. So it could be 9 compartments, it could be 4 compartments, and it can be 5 compartments, depending on what book you look at, what website you look at. But I'm going to break it down and tell you all the different variations. So you have the medial compartment. This is the first compartment, contains the abductor hallucis, flexor hallucis brevis, and the FDL tendon. Next is, lo and behold, the lateral compartment. It contains all the lateral muscles. So that would be the abductor digiti minimi, the flexor digitorum minimi brevis, and then you've got the third compartment, which is also called the interosseous compartment. You can divide this into 4 subgroups, and that'll add towards your 9 compartments, because there's 4 interspaces, and you've got your dorsal and plantar interosseous in there. Then you've got your central compartment, which is broken down into 3 subcompartments. Also, if you count the central as 3 and the interosseous 4, medial lateral, that makes out 9. So the superficial compartment is the first compartment of the central compartment, flexor digitorum brevis, and lumbricals. Then you have the central compartment, sometimes known as the 5th compartment, and that contains the quadratus plantae. Very, very important to check when you have a calc fracture. Then finally, the 3rd compartment, the central compartment, is the deep compartment. I feel like I've said compartment like a bajillion times. So anyways, the deep compartment has the adductor hallucis, the posterior tibial and neurovascular bundle, and tendons are going to be the FDL and the PT. So if you would like to count them individually, you just have medial, lateral, interosseous, central. That's 4 compartments. Count the central one, and you've got a 5th compartment. And then count the breakdowns of the central and the interosseous, then you've got 9 compartments. And you know I can't survive without a picture. So this is my way of showing you how the compartments are identified in the foot. And then also another key point to note is that the normal pressures in each of these compartments should be between 0 to 5. Sometimes when you're exercising, you can get up to 50, but normally it should be less than 5. I'm also going to throw up a picture here showing you how to check the compartments. You've got to check either you can go distal medial to check it, go through that medial compartment, and then approach the central compartment to get those pressures. You can also go a little bit more proximal to get the calc, or you can go from a dorsal approach where you get through the interossei compartment first, check the pressure of that, then get into the central compartment to check the pressures deeper down. This would not be complete unless we talked about the different kind of complications that can arise due to compartment syndrome. And the biggest complication we see is necrosis. And the key word you need to remember is Volkmann's contracture. What essentially is Volkmann's contracture is any kind of fibrosed or contracted muscle that kind of stays locked into a place. So that is another good buzzword. If you see that, you know they're talking about compartment syndrome. Next is rhabdomyosis. So this is muscle breakdown, and you'll notice that they have tons of myoglobin and creatinine kinase, which are all components of a muscle, start to leak into the bloodstream, which can be very, very toxic, and eventually it can lead to kidney failure if it's not treated. So whenever you're suspecting of a crush injury, fracture in any of the ones that we listed above, definitely double check the compartment pressures because you don't want this patient to get necrosis or rhabdomyosis later on. Also, a big thing is imaging. Get whatever images you need in order to assess the fracture, the blood supply, and what exactly you're dealing with. Now that we've covered what compartment syndrome is, the signs, and the complications, let's get into actually how to measure the compartment pressure. And this is done specifically using a wick catheter. The magic number that you need to remember for this is 30. So a pressure over 30 is a positive sign of compartment syndrome. But they can get really tricky with you. If there's a difference between the diastolic pressure and the compartment pressure and it's less than 30, that's also another sign of compartment syndrome. Let me give you an example. So let's say somebody's diastolic pressure is around 80, okay, and then their compartment pressure is 5. So if we take 80 and minus 5, we've got 75. So it's not less than 30, it's greater than 30, we're okay. Now let's say their diastolic pressure is 30 and their compartment pressure is 20. Now that difference is 10 millimeters of mercury. That is a bad sign because that is below 30. And remember, the magic number was 30. Doesn't matter below or under. You just have to really read that question very carefully if they are relating it to diastolic pressure or not. So essentially, when the pressure changes, it's cutting the blood flow to the muscle like we talked about, the nerves and the arteries and the veins, and that leads to decrease in oxygen. So that is why it's very important for this number to not change. You want to check the compartment pressures before any local anesthetic because that will definitely give you a false read, so keep that in mind. Also remember that the highest pressure is usually around the fracture site, at least 5 centimeters around the fracture site. And that's a definitely good high yield topic to remember. Again, a reminder, false readings, not just anesthesia, but hematomas can give you a false reading. So don't check it anywhere near those areas. I left a link here showing you how to actually use the instrument to check the wick catheter. So definitely check it out. It's very, very good video. Let's say the compartment pressures are very high and you have to perform surgery. So you're going to perform a fasciotomy. And this will open up the fascia and release the pressure and also allow blood flow to the foot. You can make this incision, 2 incisions over the inner space. Specifically, you can do 2 dorsal incisions like this picture shows you above with the 2 arrows along the 2nd metatarsal and the 4th metatarsal. And this is usually a preferred site during a Liz Franks injury. The next, you could do just a medial incision. This is great for any sort of calcaneal fractures and you're assuming the calcaneal compartment pressures are very high, or you can do a combination of both. Just remember when you are doing a fasciotomy, the key is to never, ever, ever use a tourniquet because they already have a lack of blood flow. You'll be restricting the blood flow even more. Also, another big point when doing fasciotomies is that you don't want to close it. You want to delay primary closure, delay any kind of application of skin graft for at least 5 to 7 days. This allows everything to drain out if need be. So when should it be done? The fasciotomy should be done at least within 8 hours of the injury. Anytime after, trying to linger it even longer, 12 hours and above, you're looking at almost irreversible damages. And any kind of open reduction, internal fixation. So if it's a closed fracture and the injury is less than 8 hours, go ahead and fix the fracture. But if you are dealing with something that's greater than 8 hours, it's an open fracture, it's like a complete mess, just delay fixing the fracture, but definitely go ahead and do the fasciotomy. That takes precedence in a situation like this. Up another picture with all the different compartments in the foot, just illustrating it in a different way. And the arrow points to the interosseous compartment. And then again, here are my other two pictures on where to place those wick catheters, dorsal or medial, and it can be medial distal or medial proximal. Another low yield topic is to check for nutrition status. This is good to see what kind of healing potential the patient has. The key lab to check is prealbumin. It's more reliable, it's less affected by the liver changes, versus albumin has a larger storage, so it takes longer for that number to drop. Let's go ahead and put our 2 stars on there and zoom out, and we just conquered compartment syndrome. I hope you guys enjoyed today's video. If you did, be sure to give it a thumbs up. And if you have any suggestions on other podiatry related topics I should go over next, leave a comment below or visit the website. Dr. CB signing off. We'll see you in the next video. Bye.